and I have given Magdi said that he had a difficult topic. I think I've been given an impossible topic. Unloading of respiratory muscles, what is this? We're talking about it and we're using the word frequently, but really what does it stand for? And what are the definitions for unloading? Especially when we talk about unloading with, say, partial ventilatory assist, when we have somebody who is breathing at the same time as the ventilator is delivering the assist. I've tried to do this very simple, and it's going to be complex anyway, I think, but I could say we have on one side the suppression of respiratory muscle pressure generation. On the other side, we have suppression of central respiratory drive. Now, do these coincide or are they different, separate? We don't know. Also, a term that often confuses this topic is the term effort. So I get an unloading by the respiratory muscles, and I also have a reduced effort. Now, what does this mean? I mean, when we talk about it, we always know what we talk about, but when we write about it, it might not always come out so clear. Now, I choose this slide from Kimura et al. To try to show what unloading comes from. And it shows on the left side a spontaneous breath, and you see the esophageal pressure swing. There is also a gastric pressure indication. We go to pressure support of 10, and you see the waveform has changed significantly. Now, what's really most visible is that as soon as the ventilator starts, there is a positive pressure deflection of the esophageal pressure. Now, is this a relaxation of the muscle, or is this a forced pressure swing by the ventilator? Going to an even higher level of assist, we see that the pre-inspiratory effort is smaller, the drive is probably reduced, and the positive swing is bigger, and it's also pushed into a level which is above FRC. Now, can we relax above FRC, or is this something that the ventilator does? Martin Tobin showed this excellent graph in the New England Journal of Medicine, and I will borrow it from Martin to try to exemplify a bit what unloading comes to when it comes to patient-triggered ventilation with pressure flow triggers when we have intrinsic PEEP. These first two lines indicate the onset of the ventilatory assist and the end of the ventilatory assist. We've seen these slides before. However, this is the inspiratory period, the ventilator inspiratory period. Now I'm putting on here the beginning and the end of the inspiratory diaphragm activation. Now, this cycle thus should indicate when the diaphragm is active. When we breathe spontaneously, normally the inspiratory flow stops approximately soon after the peak of the diaphragm activation. So, assuming that this is the period, the red one, that we actually have inspiratory flow generation in mind, at least, and that this is the period where we get the assist. Question is patient ventilator is mechanical ventilation? Sorry, I missed one point here too. The other point is also that what we see here is that expiratory flow starts almost because these patients are hyperinflated and try to breathe out. So we have an expiratory muscle activity too, which kind of occurs while the ventilator is still active. And I go back to that point again. Here comes the question again, the thing about do we get muscle injury when we do this kind of ventilation or not. I also want to point out that the actual end of the peak of the EMG activity coincides with the onset of flow. So there's really a real big mismatch. Now, is this kind of reduced? Because if you put a patient on ventilation and he has PSV and he is desynchronized to the ventilator, he will get a reduction in drive. That has been shown. Now, is this a ventilatory effect due to post-inspiratory kind of ventilation of the patient, or is this unloading of a muscle? I mean, in my mind, unloading must happen when the muscle is actually doing the effort. Viale showed very nicely in a paper that haven't got too much attention, but I find it intriguing. He looked upon spontaneous breathing, and then he put patients on pressure support ventilation. He waited 10 breaths, and then he looked upon 5 breaths. These are shown, the results are shown in this left column here. You can see spontaneous breathing. The tidal volume doesn't change. The PDI goes down when you apply pressure support. The EMG goes down, and also the total EMG goes down. So here we have a reduction in pressure generation and a reduction in diaphragm activation. Now, he puts on triggered BiPAP. So now he gives every second breath with assist and every second breath without assist. And we go back and look at the same panels here, and we can see now tidal volume goes up during the assisted breath. So instantaneous assist increases the volume. The PDI goes down, but the diaphragm activation remains constant. So if we give unloading to a patient, could we assume that after several breaths, reduced mechanical load effort would coincide with reduced neural effort? I think so. But on a breath-to-breath basis, it seems that a reduced mechanical load or effort will be accompanied by an unchanged neural effort. So the point is now, when we talk about effort, is it neural or is it mechanical? To answer this question, I will show some of the graphs that we have obtained with neurally adjusted ventilatory assist, which is a new mode of ventilation where we put down a catheter and measure diaphragm EMG. We use an electrode array. We process our signals. We use a servo ventilator to feed back the pressure to the patient. What we get is that when the diaphragm electrical activity goes up, the assisting pressure goes up. So we have an assist which is proportional to the patient's effort, neural effort, I think. This also will change not only within the breath, but between the breaths. So if you take a big breath, you get more assist because you increase your activation. Now, what's intriguing about increasing proportional unloading is that if we first look at the volumes, is that we seem to stop our maximal inspirations even if we receive increasing levels of assist. And the increasing levels of assist are shown here. So we went from spontaneous breathing to a level where we actually stopped in this subject at the peak pressure of about 60 during TLC maneuver. So this is spontaneous breathing to TLC. Now, what happens with the pressures in the chest? Well, the transdiaphragmatic pressure went down so low that it actually became invisible. We didn't see a deflection in it. And the esophageal pressure started to go positive. Now, the diaphragm activation, though, continued to stay high. We couldn't suppress the diaphragm activation to more than 40% of its maximum. We try then to see what happens if you go from spontaneous breathing to a TLC maneuver. Like if you change your drive, would that change your unloading in some way? Or is proportional unloading kind of really proportional unloading? And we have here in the upper panel 2 tidal inspirations and 1 inspiratory capacity maneuver. We have 2 breaths where we have the diaphragm EMG is very low, and the third one where it's going up. We have the airway pressure following the EMG. And we can see that the esophageal pressure swings are going positive to each inspiration. They are supposed to go negative if you would breathe spontaneously. And they match the gastric pressure swings such that the transdiaphragmatic pressure remains the same, both during small breaths and big breaths. So we have 2 small breaths and 1 huge breath. We have an increase in diaphragm activation, but we have no change in the PDI. Now, I can't understand this, so I will not comment on it. And I think there's people in the audience who are much better suited to answer these questions than I am. However, the synchrony is maintained throughout the period. Now, so if we talk about inspiratory unloading, I think we should talk about the impact of patient-ventilator interaction. I think that's very important. if we have good patient-ventilator interaction, I think possibly the primary suppression of respiratory muscle pressure generation, the primary suppression is the respiratory muscle pressure generation reduction, and the second one is the reduction of drive. I think I messed up that slide pretty bad. In terms of poor patient-ventilator interaction, the first thing that happens is you reduce central drive, and probably secondary, you get a reduction in the pressures. Now, the terms effort, I would suggest one divides that term into one thing, neural effort on one side, mechanical effort on the other side. That would reduce the confusion on the topic. So in conclusion, I think there is a need for clarification of the definitions for unloading and inspiratory effort. I think that also one should have that patient-ventilator interaction determines through which mechanism partial ventilatory assist promotes unloading. PDI provides different information than EIDI. I don't think it makes anything wrong, it's just different. And the take-home message, I think, is that optimal patient-ventilator interaction is necessary for optimal unloading of respiratory muscles with partial ventilatory assist. Thank you very much.